Hello, Dr. Sankar. How are you?
Hi, I'm very well.
Excellent.
Is somebody, is there
I'm going to go ahead and
Mhm.
introduce you now. So, hi everyone. Welcome. My name's Adriana, and I will be monitoring the chat for questions. Dr. Sankar, would you prefer to hold all questions until the end, or would you
It's okay if
want
they
it to be
want
more
to
interactive?
interrupt, but I need
Before-
to actually hear it because when I'm presenting, I may not look at the chat screen.
Well, I'll be doing that for you, Dr. Sankar.
Okay, yeah. So you can do them if it is in context of something that I just talked about. If something comes about, you can
Okay.
interrupt me. Yeah. Now you
Okay.
need to enable me to share screen.
Okay. Well, just so everyone knows, this is Dr. Raman Sankar. He's professor and chief of pediatric neurology at UCLA Mattel Children's Hospital in Los Angeles. So you're on, Dr. Sankar. So all you have to do is do your share screen at the bottom or top, depending on what device you're on. It should be a green rectangle with an arrow in it.
Can you guys see?
Yes, we can.
You see the opening slide? Okay.
I can see it.
Very good. Good morning, everyone. This talk is organized in such a fashion that it is suitable for families, but it's also got a little more data for physicians who may be participating. So I'm assuming that we have a mixed audience because in the past, when we met in Disneyland, I often popped over to other lectures and so on. And at the same time, we don't have to get excessively technical, okay? So I'm going to start by giving you a little bit of, first let's see, I'm trying to advance the slide, which, hang on. All right. These are some of my disclosures, just so you know that I serve as a consultant or advisor to a number of companies involved in therapy development over the years. And I speak for some of them. And this is kind of what I had in mind for new therapies today. I wanted to talk about, highlight a couple of newly approved seizure medications, primarily cenobamate or Xcopri and fenfluramine, also called Fintepla as a branded product. I wanted to talk about new indication for something that's already previously approved. So I will just mention it without any specific slides on it. And then we have a new era in seizure rescue therapy. For a lot of my patients, this is actually a big deal. Regardless of what medication they are on, it's good to have some options for rescue, and they have dramatically increased compared to where we had been. And I'm going to give you a little bit of a sense of what's going on in terms of the future. How are we evolving in terms of development of new drugs? And I'll talk a little bit about it. And some of that will occur towards the end. Okay. So I'm going to talk a little bit about a new medication called Xcopri. I realize the audience for this session is predominantly youngsters. This medication right now is indicated for older people. However, there may be a potential application. As you know, all medications start that way and eventually find their way. And I just wanted to let you know that I have minimal experience at this point, but I do have some favorable experience with some teenagers who had failed multiple therapies, those who had focal epilepsy. So it's a medication for partial epilepsy For the physicians in the audience or any family whose family member may be a chemist, I'm showing you a structure of cenobamate on the left, on the top, and below is a structure of a highly effective medicine called felbamate that has a lot of history. And you can kind of see how there is a resemblance of what we organic chemists call, this is called a carbamate moiety attached to a ring. You see the same thing there. However, felbamate had a unique vulnerability right here in that position I'm circling due to metabolic reactions where it could go to a toxic intermediate. We don't really have that type of a scenario with cenobamate, so we don't really expect that. But it does seem to show very potent activity. Okay, so it's indicated for partial seizures in adults with potential applicability. One of the reasons many of us in the business think it is a particularly noteworthy one is because compared to many recent approvals, we're seeing a higher percentage of people who are benefiting from it, even though the FDA requirements are often 50% responder rate, 50% reduction in seizures. But what you see here, actually on the left side, you see the various doses that are color coded. The purple one is 200 milligram, probably one of the most common doses used. In a couple of younger patients, I have stopped at 100 milligrams, which is the red bar. But even there, you get a very statistically meaningful reduction. The 55% reductions that you see are uncommon in this business if you compare it to various medications. And over here, you find another remarkable thing. That is, most of the time, the FDA only looks at 50% responder rate. Okay, if you look at that here, 50% reduction was achieved by fully 75% of the patients, which is a very, very dramatic number. It goes beyond what we are used to. On the other extreme, you can see on the right that 20% of the people actually became seizure-free. This is also uncommon in a refractory population. And the one patient I have who's a adolescent had almost daily seizures when I started her on Xcopri. And at the present time, over a month to 6 weeks, has been seizure-free to the best of my knowledge. But as I mentioned to you, I do not have a large number of patients on it, but we are quite excited. It's a matter of time before it becomes approved for younger people. And the other important thing, what do people need to see? Here, you can see that over up to 30 months, this is the long-term seizure reduction plan. And you can see here that the reduced seizure frequency is well maintained. The purple bar is on medications. The turquoise one is the one on placebo. And over here, they enter the study, and then they pretty much belong to the same group. So there is very, very substantial. Again, you can see 75% seizure reduction maintained for 3 years is distinctly not what we commonly see. So we do think it's a new achievement in drugs made for partial seizures, or what we call focal epilepsy. Okay. And one of the important things, this is not a promotional talk, so I'm not going to be going over every mandated safety issues. I'm not going to talk about dizziness and sedation and all the usual thing. What is unique about this medication is a high incidence during the early part of the trial that was seen with this usually less common reaction called DRESS. or drug reaction with eosinophilia and systemic symptoms. This is a little bit reminiscent of what happened way back when, those of you who are old enough, especially that are practitioners, we kind of dealt with something similar with Stevens-Johnson's and lamotrigine. We had a big flurry of concern in the initial period, and then we learned an important lesson with that. And the lessons are very similar. We learned that we can pretty much avoid that by simply titrating very, very slowly. So any of you in the audience who have a child or an adolescent on lamotrigine, Lamictal, you already know you took a few months to get up to the dose. And that's really very similar. So this is also like a autoimmune allergy-like reaction. And what we have mandated then is a extraordinarily slow titration. Unlike most other medications, even though my patient's dose of Xcopri may be 100 to 200 milligrams, we start at 12.5, that low, okay? That is, as you can see, if your final dose is going to be 200 milligrams, that's 1/16 of the dose. Not only that, you're going to stay there for 2 weeks at that super small dose. Then you go to 25, 2 more weeks. You go to 50, 2 more weeks. So it's going to take fully 2 months just to get to 100 milligrams. And if you want to get to 200 milligrams, it's going to take basically 3 months approximately. So that's kind of really, really important to know. Generally, I think I have only come up to here on my limited exposure to this. And so that's one of the new things. Okay. Then the other new branded medication that got approved in the past year is Fintepla, also called fenfluramine. There has been a great anticipation for the approval of this medication for quite a few years because it is specifically approved for Dravet syndrome, which has been extremely difficult to treat with all the existing medications. With fenfluramine or Fintepla, we really have a previously unachieved level of control. Okay, and I just wanted to show you that its indication currently is specifically for the diagnosis of Dravet. Many of you know there are 2 ways to go about it. You can make a clinical diagnosis of Dravet. You can supplement it with a genetic diagnosis, like whether you have a mutation in SCN1A. Important to remember that not everybody with SCN1A mutation has Dravet, and not everybody with Dravet has SCN1A mutation. So it's possible that you have a mutation in something else, but fulfill the criteria clinically to be called a Dravet syndrome or variant. Okay, and one of the interesting things about this drug is there is a mechanistic risk for valvular heart disease. The other important question many people have in their mind is, where did we learn about this? What is the story, backstory? Well, the backstory is long time ago, there was a medication combination. Many people knew that as fen-phen, which is fenfluramine and phentermine. That combination was used by adults for weight loss. And then some of them got into cardiac difficulties. The reassuring news, now we have understood a lot more about it. We think it is related to activity at this 5-HT2B receptor. However, in this population, with the dose used during the entire clinical trials leading to approval, we have not seen anybody with changes in valvular thickening or with pulmonary hypertension. So far, the data is very, very clean. However, monitoring of it is required. So if anybody is going to go on this medication, they do need to get a cardiac echo. It has got what is called a REMS program. Some of you may have had children who went on vigabatrin or Sabril in the past and had to deal with a REMS program. The REMS mandated by the FDA stands for Risk Evaluation and Mitigation Strategy. That means there is a specific risk for which you have to monitor. And in this case, it is valvular heart disease. The reassuring thing is, so far we have not encountered that on anybody, okay? So here it is, to cut to the chase. Again, you see here seizure reduction. The gray bar is placebo. The red one is the 0.2 milligram per kilogram per day, which is not the target dose. It is just a place where you go for titration. The typical dose is 0.7 milligram per kilogram per day. And what you see here is a nearly 80% reduction in the seizure frequency. I can tell you with great confidence that no other medication for DRAVET has achieved 80% seizure reduction. What is really kind of interesting, but a lot of time neurologists don't talk about it, to understand some of these, you heard me talk about Xcopri and 70% approach, is, even in what we think of as not very challenging epilepsy, like childhood absence, medications in clinical trials, like the famous trial of lamotrigine, valproate, and ethosuximide, none of the drugs achieved responder rates like this, okay? So in terms of responder rate, this is seizure reduction. And here you can see seizure reduction, again, proportion of patients achieving that, you have a 70% response, okay? So more than 50% of the patients on that dose had a profound reduction in seizures. So these are very remarkable numbers on a very difficult type of epilepsy to treat, okay? And here is the post hoc analysis that also showed that 1 in 4 patients, that is 25%, that went on Fintepla, which is fenfluramine, at the 0.7 milligram per kilogram, had only one single seizure during a 14-week treatment period. Now, if you have a child with significant epilepsy, 14-week seizure-free is good for any kind of seizure, leave alone DRAVET. So it's very, very remarkable and very, very robust, okay? So here is one of the open label extension. This may be highly reminiscent of what you saw with partial seizures, adults, and Xcopri. Again, we are kind of coming all the way down to the neighborhood of 70 to 80%, and then hanging in there for 3 years. So these are the 2 new medications, both of which I think are very impactful, okay? And there is another trial that the data I showed you did not include people who received stiripentol. In fact, those patients were excluded. There was also a trial with patients who are on stiripentol, and there again, it achieved very dramatic difference from placebo. And this is an unusual way of showing you the data, reduction in mean convulsive seizure frequency versus percentage of patients. So you can see here 50% reduction was achieved by 55, 60% of those who are already on fenfluramine. Okay. And so regarding side effect, we told you the story of fen-phen. And as you can imagine, the most noteworthy thing was reduced appetite to watch for on fenfluramine. Okay. So this is kind of what the cardiac echo paper looks like. It's a very, very simple screen. Notice aortic valve, mitral valve. All they have to check is absent or trace, mild or moderate for regurgitation, right? Similarly, again, it can be all the way to severe. Basically, what you expect in most kids is these two boxes will be checked. And here, elevated systolic pressure in the pulmonary artery, valvular abnormality, or any new, you expect the average to be no, no, no. Okay? And then you will have to, this form goes into the company and the REMS program to get the medication started. All right? So something else, if I were to talk about this is again similar from another study. This is the group of Dr. Levon Leger has been using fenfluramine for the longest time. We heard about the fenfluramine history with fen-phen. Some of you may be interested to know that the drug is not terribly new. It was actually used by Henri Gastaut, if you recall that name from the Lennox-Gastaut syndrome. Henri Gastaut used it in photosensitive epilepsies way back when. Okay. The other important thing, again, if I were to give a company fenfluramine talk, I cannot mention it, but this is not a company talk, so I can say anything that is scientifically valid. And one thing that really intrigues me is many patients these days are concerned a lot about SUDEP. We have learned a number of things about SUDEP mechanistically. There's a lot of research going on in SUDEP. And one thing we have learned is brainstem mechanisms involving serotonergic transmission. The neurotransmitter serotonin may be important in mediating SUDEP. We've been noticing that for probably 15, 20 years now in the basic science laboratory. One thing that I found interesting also, I mentioned in the opening slide, it is the only anti-seizure medication we have that actually works through serotonergic mechanism. So it's obviously of some interest to know, given that DRAVET patients have a high incidence of SUDEP, so does DRAVET mouse. So one group that has been studying a different mouse breed called the DBA mouse that also has a lot of SUDEP found that fenfluramine actually prevented seizure-induced respiratory arrest. What they found is it's a mouse model of SUDEP, and they found that it was not because it controlled the seizures. It was an independent effect. How do we know? It blocked respiratory arrest at a dose well below that required for controlling seizures. So it's an independent property of fenfluramine. Now, we do not have any human data, so I want to be very careful. That is also why if you ever went to a fenfluramine Fintepla branded talk, I can't bring this up, right? The FDA will be all over me. However, as a epileptologist and as a neuroscientist, it's very intriguing to me because we do not have any other approach to SUDEP at the present time. The approaches we have are indirect. That is, we can say that whether it is neurostimulation or epilepsy surgery or a powerful new medication, if you control convulsive seizures. So at the moment, for convulsive seizures, you would say, the Excopri or cenobamate is a new one. The other drug with a lot of data specifically on convulsive seizures includes perampanel, right, which you know as Fycompa. Those may have an impact indirectly on SUDEP because they are reducing convulsive seizures. However, with fenfluramine, this was seen even before it control the seizures at a lower dose. So that's kind of an exciting development. Okay. Then there is a related medication called lorcaserin. This is an interesting medication. It had the trade name of Belviq and was voluntarily pulled off due to very, very trace concerns about malignancy. However, the FDA does not think the risk-benefit ratio is unfavorable at all for bad epilepsies. So for those who may not tolerate fenfluramine for whatever reason, lorcaserin could be a new option. It is a drug that is currently undergoing a trial. Just for those who may be interested, I am one of the investigators for lorcaserin. I haven't started the study yet. My study initiation happens in a couple of weeks. And so that's an option for some people with, if you have clear Dravet syndrome. One potential importance of lorcaserin is it is not an agonist at the serotonin site that involves cardiac valve thickening. It's a purer medication for seizures and appetite. Okay, so that's a trial we're going to start in a couple of weeks. And the next topic I'm going to go into is advances in rescue therapy. We have gone nearly 20 years with the only option for rescue therapy that was, highly effective and proven was a rectal gel. So rescue therapy has been underutilized. We have used some other modes of rescue therapy without very good data. That is, some people have used injectable midazolam in the nose, but we don't really know what the bioavailability is. One of my patients used to complain to me that it was highly irritating to his nose and he hated it. And in general, we did not have a lot of options. And it was not also a contraption that anybody could use because you had to really assemble the thing, right? Not to mention getting approval from insurance. So there were many, many, many hassles. Now we have actually choice of 2 new medications. They're not new medications, really. They're both old medications, but 2 new dosage forms. They both come in these kinds of inhalation type of devices. It looks exactly like this with a finger grip and a nozzle that goes into the nose and a plunger that you push. The device looks identical for a product called Nasalam and another one called Nasalam over here and Valtoco here. And here you can see the finger grip, nozzle, and the plunger, okay? Now, I'll talk about Nasalam first. It's used for seizure clusters, or you can use it for prolonged seizures. It can be administered by non-healthcare. I've been on this fight with both these companies for misleading people, which is it always says no priming is necessary. That's a wrong statement, okay? The correct statement is do not prime. Because if you get this by a prescription from your doctor, see if you push it with a thumb to check it, it's done. It will lock and there is no more medication. Okay? So priming not necessary is a stupid thing to say. Doctors should be telling, do not prime. It's not designed for priming. It's one push and it's gone. Okay? So it can be administered, very similar to the way we have used rectal diazepam before. And you do not need the patient to be actively inhaling because we are not targeting the lung, understand? So it's really for the nasal mucosa. So even if the patient is unconscious, if they are seizing, it can be very, very effective to stop, okay? And So this is the data for Nasolam, which is midazolam. Some of you know midazolam as Versed. Some of you may have used the injectable form of midazolam with a little atomizer attached, but that was not really meant for the mucous membrane, and there is no data. Whereas here we have data. You can see the difference in probability of another seizure, right? So it comes in a package of 2 units. Each has 5 milligrams. You may use just one, or if the seizure recurrence occurs, you can use a second dose, and for a total dose of 10 milligrams. Okay, so the first dose in one nostril, if the second dose is needed, after 10 minutes, you can use a second dose in the opposite nostril. Don't use more than 2 for a single episode, right? And no more than 1 episode every 3 days or 5 episodes per month, because if you keep needing to use it, it may require some adjustment in your baseline medications to get better control. But as you can see, it looks a lot like some of you with migraine may have used sumatriptan inhaler or other inhalers that are made exactly the same way. And this shows also that return to activity with this intranasal midazolam dose is very good. This is return to baseline within 24 hours, but the median time actually is only 90 minutes. That goes with the fact that Versed or midazolam in the hospital setting is often used as a drip because it's very, very short acting. Okay. The other one, notice that the inhaler looks exactly identical, except for the label, is a new product called Valtoco. Valtoco is basically diazepam, right? And it's a new product with some interesting twists. Now, this is old data that was found in 1998, 22 years ago, that brought approval of Diastat, the branded version of the rectal diazepam gel. There were 2 pivotal studies, one published in New England Journal of Medicine by the very famous late Dr. Fritz Dreyfus, that repeated 1 dose, just like we talked about, after 4 hours though, because Valium or diazepam is long acting. And here again, you can see probability of seizures, placebo versus Diastat, right? Probability of no seizures rather. And over here was a single dose study done by Jim Seragino from Oregon, published in Neurology the same year. These were the 2 pivotal studies that got Diastat approved originally, okay? And what is different about Valtoco is, first I want to draw your attention to this FDA guidance of 505(b)(2). This is an alternate pathway because if a medication has already been shown efficacious, such as we saw here, right? All you need to show with a new product is this is a new product, but not a new medicine. So you need to only show that you achieve blood levels comparable to that old product, that rectal diazepam gel. And it turns out it actually meets or exceeds. It's an extremely interesting product because the technology here is something that's very interesting. It has diazepam, the ingredient, which is Valium. It has a very interesting surface active molecule called Intravale. It's sort of a patented product made by a company that has been acquired by this company, Neurelis. So it's part of Neurelis now. And it uses vitamin E to increase the solubility. One of the challenge with these fatty drugs is, see, you cannot have a large volume, right? It's just a spray. You don't want it to drip down. you want a very thin spray on the nasal mucosa. The volume needs to be really small. And the challenge is, how do you dissolve a highly insoluble molecule? So in this case, they used vitamin E to increase the solubility. So there's a little bit of touch of vitamin E. Then this surface active agent called Intravail is very interesting because it actually is a permeation enhancer. Okay, for those who are technically inclined, and if you are a doctor in the audience, I will show you what Intravail is because I'm pretty excited about it. Some of you may have heard I'm an old chemist, right? So the Intravail, it's a non-ionic surfactant. For instance, your detergent that you wash clothes with is a cationic detergent. Old-fashioned soap is an anionic detergent, surfactant. This one is non-ionic. It's got this long fatty chain and a sugar-like molecule that is very water-loving. This is water-hating, right? So these kinds of compounds, the length here can be modified, but these are basically alkyl polyglucosides. And what it does, you can see here some examples on drug delivery. So with Intravail concentration, here you see bioavailability for calcitonin, leptin, insulin, and so on. Here is another one for insulin in the green monkey using Intravail. You can see here when it is administered, the glucose or insulin level, how this works, right? And this is the glucose level. It's high. And then here is the injection of insulin. You see sudden spike in insulin and the glucose starts coming down. So what Intravail does is allows the glucose, the insulin here, or in the other one, you can see data for insulin, calcitonin, leptin, all kinds of compounds to get right through the nose. So it's really impressive technology. It fascinates me as a chemist, the formulation side of Valtoco. And Valtoco is approved for younger patients than Nasalam, okay? Nasalam is approved for 12 and older, and you can use this for younger patients. And here is the blood level curve. The light green is intravenous 5 milligram dose, and this is a nasal solution, 10 milligram. And you can see how the level is fairly sustained over time. Also, you do not get as high as the IV, right? So you don't have as much toxicity. This is the range of concentration where you get a good benefit. Here is another one showing the yellow is 5 milligram, maybe hard to see. This is 10 milligram, the dark green. And then you can see light green with the repeat dose. See the light green continues like the grand, and then for 4 hours, you get a second dose. And then that is similar in the long 8 hours and past to the 20 milligram dose, which is in gray. So the idea is you get very healthy levels. The dose available is, includes 5, 10, 15, 20, depending on how you want to use. And before I go there, let me also tell you, it's again packaged with 2 units, right? So if you want 15 milligram dose, you may use 2 7.5s and so on, okay? If you need a 20 milligram dose, it may be 10 times 2. So each pack has 2 dispensers. And so far, we are having pretty decent luck with both these steps and getting approval. A lot of my patients are very happy. And I do want to emphasize to you, if you get it, do not try to prime it, because if you prime it, you lose it, okay? Finally, I want to tell you a little bit about how we are beginning to approach drug development. The historic approach has really been using not epilepsy models, but seizure models, right? We have ways by which we can make a rat or a mouse have a seizure. We can give electroshock, we can give some chemicals, and then we try to see how the drugs protect them. So there is a gap in the real disease versus how the drugs come. But that is beginning to change now. There are new models that use stem cells, but the limitation with stem cells is there isn't really an epileptic network, right? There is no phenotype. Phenotype meaning semiology or the expression, what the seizure looks like, what happens to the organism. You can't really see that. You can only see excitability in a single cell, right? Then people are also using things called zebrafish because it's very easy to put mutations of genetic epilepsies into it. And things like fenfluramine, you can show very nicely that you can put the SCN1A gene into zebrafish, that mutated gene, show a form of seizure-like behavior and control it. Then there are, of course, transgenic mouse models. These are much more labor intensive, but they also have much more of the behavior, like a complex partial seizure. They have much more of the pathologic change in the hippocampus and so on, right? So these are all different types of models. But now, one of the important thing is, even with DRAVET, people are looking at another entirely new approach, which is using a medication. Some of you may have participated in a trial called TAC935. It's being used for a number of very complex epileptic encephalopathies, including Lennox-Gastaut. That is a cholesterol 24 hydroxylase inhibitor. May not be a most obvious target, but it apparently changes some excitatory signaling by glutamate. So I won't go too much into mechanisms, but just to tell you that we are looking at an extremely different hypothetical signaling pathway rather than electroshock seizures. Okay. Then there is a natural product that's under trial, a Chinese herbal medicine called huperzine that is being tried and seems to have protection in the Dravet mouse, and it is being now evaluated. And then there is another thing I wanted to talk to you a little bit about Dravet. I am trying to show you what's the problem with Dravet. I hope it is simple enough. The Dravet mutation is in these neurons that I've drawn as an ellipse or an oval that I call SCN1A interneurons. So right here, I show a sodium channel. This is the one that's impaired. When the sodium channel is working, what happens is these neurons drizzle GABA on the principal cells, like so, right? And when this is mutated, there is insufficient GABA, so you get a seizure. So now what some people are trying to do is go right in and start playing with genetic technology. And that can be done in different ways. Okay? So this is the idea, to restore GABA release. So how do you do that? So one company that is doing human trials now is a company called Stoke Therapeutics. And what they are doing essentially, don't try to get too involved with it unless you know a lot of biology, but they are looking at the fact that here is the DNA, the orange is the right DNA, the red is the mutated DNA. Now what they are doing is a technique called antisense oligonucleotides, right? This is you're going to hear more and more and more about it. It's already the approach of antisense oligonucleotides used in spinal muscular dystrophy, lethal disease in babies, right? And there is a medication that is called nusinersen that is given, where what it does is this, see here, ASO, that stands for antisense oligo. It goes to bind with the mutated one, and it essentially inactivates the mutated message. And that allows the normal message to be translated more and made into viable protein. So one of the issues with this is when properly designed, it can be, as it is shown in spinal muscular atrophy, life-saving. In animal models on the seizure in the DRAVET system, very, very effective, and human trials are underway. The one thing though, is this is not same as gene therapy. This is gene expression therapy. The difference is we're not actually modifying the gene. We are using a small molecule to interact with the defective gene and block it. So you have to keep giving this. The period can be anything from 2 weeks to 2 months, but you will need regular intervention. You don't need daily taking like a regular medicine, but it is not like a one-shot thing like a gene therapy could be. And that too is being considered. Okay, so, and that is the upregulation by basically, there is some oligonucleotide treatment. There are some articles that I give you a thing for doctors. You don't have to worry about it. But I want to show you the other one is using a viral vector, where you actually bring the good gene. You use a fake virus, which carries the gene. It's like a Trojan horse. It takes it into your neuron and replaces the missing part or corrects the missing part. When you do that, potentially it's one treatment. Now, the one gene therapy people have been doing for quite some time now is not in a neurologic disease, but severe combined immune deficiencies, you know, the bubble boy type of thing. And there is a treatment that is a gene replacement. The latest in neurology is for neuromuscular disease like spinal muscular atrophy. There is a gene replacement therapy that is currently the most expensive treatment available. It's a product you may have heard of if you watch the Wall Street page. It's called Zolgensma, and it retails for $2.1 million. But you treat only once. And I've been involved in a trial that involves another such vector for adrenoleukodystrophy, again, another lethal disease. ALD is what some of you may remember from a movie long time ago. Okay, so these are some of the things in the pipeline. And oops, sorry, wrong direction. The idea is we are going from simply creating acute seizures with electrical shock to targeting specific diseases. We also know there have been development in tuberous sclerosis. This year, it's not a new drug, but Epidiolex got a new label for tuberous sclerosis. There are other medications where we're looking at understanding the signaling pathway. Can we use it in a baby with TS diagnosis and prevent the development of the epileptic and other problems? So exciting things are in the way with new technology. For the neurologists, if you are interested in medication-resistant epilepsy, there's a new book that my colleague, Dr. Stern, and I wrote that just came out. I brought this book mainly to show you, not just to plug it, but there's a chapter on drug development, models used. And that's kind of my chapter in which I go into a lot of details about how we try to model complicated epilepsies and develop medication. So if you are a professional, the book may interest you. It's on Amazon and other favorite retailers. And I'm going to stop there and leave the last 10 minutes for any audience participation or questions.
Right now, Dr. Sankar, I don't see any questions in the chat box. So if anyone has questions, please go ahead and type them in, and we will be more than happy to answer them.
You'll have to put it in the chat box if your mic is silenced and you don't have mic control.
Correct.
I don't know. Adriana, does the audience have control over the mic?
Most of them can unmute themselves, yes.
Okay.
So if you
If
want
you
to
are
ask,
able to unmute, you can consider, certainly speaking up.
there was a lot of information, great information presented by Dr. Sankar. So please ask any questions you may have.
Anything? Let me see if there's anything in the chat box.
There is one right now. Is a
Okay.
rescue medication necessary if my daughter's seizures are currently controlled? That's from
Okay.
Christina.
Okay. If they are well controlled, some people take the point that it is still worthwhile to have a rescue medicine on hand, because sometimes children with epilepsy remain well controlled until there is a trigger, like an infection. And we are approaching winter time and respiratory infections. And others have other triggers. Some adolescent girls may have a trigger with hormonal cycles, like menstrual period. The whole idea is, I prescribe this to many patients, telling them if you never use it and it just expires, that's actually a pretty darn good outcome from my point of view. But it is good to know that it's there. And some people feel particularly so when they travel. Like right now, I know none of us are traveling, but during a normal era, sometimes I've had patients who had seizures mainly broken through and they had major changes in time, jet lag. And they felt more comfortable carrying some sort of a rescue. But, I'm not going to say it's mandatory, but it's a matter of peace of mind, having a sense of control that it's actually in your hand, that you may be in a situation where it's not practical to call 911, but it's definitely a good option, I think.
Dr. Sankar, we do have a couple more questions.
Sure.
Are there any new treatments
I see Candy and Brad. Look at that.
for Unverricht Lundborg disease to treat the progressive myoclonic epilepsy?
Yeah.
Hey, Dr. Sankar.
Hi, how are you? Good to see you.
Epilepsies.
Hi.
Why does it say
Yeah,
rare?
we don't have,
Because that's too long.
anything
I'm
specifically
not epilepsy. No,
for
but I had
Unverricht
it.
Lundborg. It's
Oh.
very hard to do a, trial. What I eventually hope will happen with Unverricht Lundborg is again going to end up being some form of molecular gene therapy, addressing the cause. However, if you are treating significant myoclonic epilepsy, we have limited type of data for a number of things that's not really new, like zonisamide. Among the new medications, it would be interesting to see whether they benefit from brivaracetam, for instance. Otherwise, clobazam could be an option, but that's not that new either.
They have to be able to swallow pills, right? To do either those.
No, not true. Both are available as a liquid preparation.
Really? In the US?
Yeah, one more thing about clobazam. We can talk about it as a new mode. It also comes as a film. So if somebody has swallowing problem, you remember the old days when they used to have a Listerine film, a little blue thing that you peel off and put on your tongue?
Hmm.
There is a version of clobazam like that. Okay, it's made by a company called Aquestive, and it's called, the brand name is Sympazan. So if you have somebody with neurodegenerative condition and severe myoclonus, Sympazan could be a potentially interesting approach.
How do I spell that?
Sympazan. Sympazan.
C-A-Z-A-N.
Yeah. It's one way of getting, what people used to under the brand called Onfi or clobazam.
Oh, okay. We have done Amphi, and it was a huge no. But I know Brevisetant, the
Yeah,
Briveeta.
Briviact. Yeah,
Do they have that in a liquid form?
they do.
Oh,
Yeah, it comes as a liquid, of course. Any other questions, comments?
Oh, sorry, Dr. Sankar. I just read a question and did not realize I was on mute.
Oh, okay.
Have you seen kids with cavernous angiomas have seizures controlled with medication or surgery? This is from Nancy.
Cavernous angiomas are a well-known cause of partial or focal epilepsy. And what was the question about?
Have you seen that the seizures can be controlled with medication or surgery?
Well, both options exist. Not everybody undergoes surgery. It may depend on the location and the size, the risk they pose, etc. But they are, when in a non-eloquent area, typically readily operated upon. There have been also a number of academic discussions on whether you should take just the angioma, also the area around it. Because sometimes, you have a lesion and the seizure is not coming from the lesion, it's coming from the, what we call the perilesional round. But if you have a cavernous angioma as the cause of your epilepsy, you should definitely, your neurologist needs to be an epileptologist who, obviously, if they call themselves an epileptologist, they likely have a relationship with a epilepsy surgeon as well.
Yeah.
But
So
sometimes we refer cavernous angioma surgery at UCLA to actually a cerebrovascular surgeon rather than the epilepsy surgeon.
interesting. My son actually had he had a brain bleed from the angioma, and they removed the angioma because it was basically causing him to die. And it was in his frontal lobe. It was his right frontal lobe. So he lost feeling in his left side, and they didn't take him in for surgery until his left leg started seizing up and he lost feeling in his left side.
Yeah.
So
Like
he's
yeah.
gone almost 3 years with no seizures or anything. And just this October 4th,
Yeah.
he had a seizure. And now since then he's had a few of them. And all they're doing is telling us, you're going to be on Keppra. And so they have increased the Keppra and haven't really offered anything else.
I can, let me address this conceptually, okay? I
Okay.
can't give specific advice for a patient, but I'll tell you what we usually do for some of these tumors and vascular malformations. I mentioned to you, we often let the cerebrovascular guy do this, but if we sometimes a suspicion of a complicated epilepsy, one approach is to do the surgery with the epilepsy group, right?
Mm-hmm.
So you can actually, once you have opened the, skull, and once you are on the brain near the angioma, again, the technique is going to vary a lot depending on its size and where exactly it is. You can do two types of things if you have the epilepsy doctors with you, with the surgeon. They can put electrodes, they can record whether epileptic activity is also there in what I call the perilesional area. In other words, sometimes you need to take the lesion plus maybe a few millimeters further, right, to reduce the likelihood of epilepsy. The other thing you can do is functional mapping, right? You can see whether it goes near something that controls important function, like how, language to motor.
Yes.
You can make an educated judgment on saying, should I, this is what we do with tuberous sclerosis, right? It's not always the tuber where the epilepsy is from. You need to take the angioma because of the bleed. But when you are at it, it would be really good to know, if you can put a few electrodes and see whether there's a lot of epileptic activity 3 millimeters from your resection margin, you may say, I need to take that. But that requires teamwork, right?
So they did.
I'm sorry. I just wanted to let you know that we are after 12 o'clock and there is another speaker who is waiting. So I just wanted to give you that information. And I did copy sound some of your questions that were not answered. And I will get that information to you, Dr. Sankar, and you can answer them and possibly forward that on to the organizers here of the event.
And for Ms. Casey, you
Yes.
are welcome, of course, to seek a consultation with a good epileptologist.
Yes.
Depending on where you live. If you are in
Okay.
Orange County, Dr.
Yeah.
Bennett is a good source.
Unfortunately, we're with Kaiser. So we've already spoken with Dr. Sarko, who's amazing, but the neurologist is he's countering what Dr. Sarko is saying, which is kind of frustrating. So I think we make another appointment with Dr. Sarko on this.
Yeah, because Dr. Sarko does have a working relationship with us at UCLA.
Yes.
You can speak to Dean and see if you can get a second opinion or explore options.
Okay.
I can't give a lot of advice because I really don't know the case.
Okay.
Yeah.
All right.
Okay.
Thank you so much.
Okay. And to all the audience, thank you all for your attention. And I hope it was not too technical and gave you some practical information on what's going on.